health at Grand Erie Public Health, Brantford Brant. Thank you all for joining us today to celebrate Sexual Health Week. A special thank you to the Sexual Health team for organizing this event, as well as to Dr. Sockatch and Patrick O'Byrne, who will be our speakers today. This week, we're highlighting the importance of sexual health and wellness for everyone, everywhere. We've seen a rise in syphilis cases, both locally and provincially, so it's essential to focus on correct staging and treatment to break that chain of transmission in our community. To kick things off, I'd like to introduce Tanya Reddix, who is the nurse practitioner with our sexual health team. Tanya will be sharing an overview of the services that the sexual health team offers and will also be the chair today. Welcome, Tanya.
Sorry, just had to switch up our display here. Thank you, Philip. I want to welcome everyone to the Syphilis and Primary Care virtual session. Thank you for making time in your schedules to attend. To give you some background around our sexual health clinic, we offer STI testing and treatment, contraceptive options, free barrier devices, pregnancy testing and options counseling, pap smears, as well as PrEP starts. Our clinic is meant to serve those experiencing barriers to accessing care elsewhere, for example, marginalized populations, those without a family physician, and those without a health card. Our team is small but mighty, comprised of our manager, Philip, our 2 full-time public health nurses, Susan Cosper and Shauna Wilson, and myself. I am in the clinic Mondays and Wednesdays and Thursdays. Some housekeeping before we get started is that please use the chat function to submit any questions. If we're not able to answer all the questions submitted in the time we have today, we will send the responses with the post-session survey. Also, if everyone attending can please add their email to the chat so we can send you the post-session survey and slides. We'll start our session today with Dr. Sockatch. Dr. Sockatch is one of our infectious disease specialists at the Brantford General Hospital. Dr. Sockatch is a wonderful local provider and a great resource. And I'm just looking to make sure he's here. Hang on. Where are you, Dr. Sockatch?
I'm here.
Oh, there you are. Sorry, you're on the other screen.
Hi.
So I'll hand the floor over to you, Dr. Sockatch.
Oh, I'm not sure what I meant to say, but
I guess just saying hi and just letting people know that you're there and how to access you.
Yeah, sure. Right. So I'm Tom Sockatch. I'm an ID doctor. One of the members of our ID team at the hospital. There's myself, Dr. Glavin, and Dr. Kalina, and so we're certainly available to see a variety of infections that might be relevant to you guys, whether sexually transmitted or we're seeing a lot more TB these days. So any of those are fine to send to us. We have very quick turnaround time for seeing patients, usually within a week or two. And so our fax number is, you can find on the CPSO website, or you guys probably have it in your system there. So nice to meet you guys. We're happy to help you as we're able to.
Okay.
I think you're muted, Tanya.
Okay. Sorry, everybody. My mouse wandered off the screen and I couldn't get it back on. Okay. So today I have the pleasure of introducing Dr. Patrick O'Byrne. I've attended his sessions previously and I found them extremely informative and helpful in supporting my practice. Patrick is a professor of nursing at the University of Ottawa and a nurse practitioner in Ottawa Public Health Sexual Health Clinic, where he has provided frontline clinical services for over 20 years. Dr. O'Byrne is co-author on the Canadian PEP and PrEP guidelines and is a lead for GetaKit, an online testing platform in Ontario that links with over 15 public health units. The floor is yours, Patrick.
Thank you for that introduction. Thank you for having me. I'm going to just share to my deck to get this part out of the way, and then I'm going to make it so I can see again. Excellent. There we go. So again, thank you for having me. As Tanya just said, my name is Patrick O'Byrne. I'm a nurse practitioner I've worked in the STI clinic in Ottawa since about 2003 or 4, providing frontline clinical services every week. I'm also a professor of nursing, doing research, specifically focusing HIV, STIs, syphilis as this main sort of area. So really what I wanted to do today is talk about breaking this down so that syphilis, which is probably one of our more complicated bacterial infections, at least in STIs, trying to make it into simpler, more manageable parts. And why are we here? As Philip said at the beginning, right, rates are up. So these are actually the local ones for Brent. The amalgamated health unit data will be forthcoming, but this is basically going into the past. 2023 was where it was still Brent. And so you can see the numbers between 2014 and 2023, 2021, actually quite a big jump. But you can see these numbers, a pretty good upward trend. That's part one. Numbers are increasing. The second main point to these trends is if you actually look at the graph that's in the lower right, there's that purple group, that color bar that's actually increasing more, and that's among females. So if you go back 2016 and before, there were actually almost everywhere in Ontario very few to virtually no new syphilis diagnoses, infectious cases in females, whereas it actually has been increasing year over year over year over year. And why? What is our sort of main concern with this? It's congenital syphilis, right, and all of the problems. And at the national level, when looking at 2022, you can see these incredible increases. Ontario actually reporting an increase of an astronomical 2,540% in the case rate for congenital syphilis. The absolute numbers, 27, not very high. But it really goes to show that this is something that historically we had not been dealing with. In fact, in 1999, the Public Health Agency of Canada said we were going to eradicate syphilis. And in 2000, the United States Centers of Disease Control said we would eradicate syphilis. And going back to this, looking at the numbers, they ended up, unfortunately, being catastrophically wrong. But this created a few sort of situations where we have a full generation, right, 10, 15 years of healthcare providers who didn't receive any clinical training, would never have seen cases. And now we're out in practice, and it's something that we are encountering and we are seeing. And if we want to go further to the complexity of syphilis, it's basically the saying is if you know syphilis, you know medicine. And that's due to the fact that syphilis is a differential diagnosis for almost every condition and vice versa. So it's just, you have to know an incredible number of things, and you always have to be thinking of syphilis and ruling it out, because as we're seeing the demographics change, and then congenital syphilis and the catastrophic problems from that really are starting to rise. So a quick overview, people are pretty familiar with this part. I'm just going to highlight two key sort of caveats and nuances before we get into more of the actual nitty-gritty details. What do you need to know day in and day out? To acquire syphilis, we know it goes through a primary phase, a secondary, into an early latent, a late latent, and then a subset of people will move on to tertiary. We like to write it out in a linear fashion, but taking a look at this, you can see that the arrows actually move in a couple different directions. People will relapse, right? You can have primary and then a gap and then secondary. You can have primary and secondary symptoms present simultaneously. Someone can lose their symptoms, become early latent, and relapse into secondary syphilis. So it is, in fact, much more complicated than the typical 1, 2, 3 stages that we like to think of in our head. And the other key point, so that's one, that it's not super linear. The other key point is early neurosyphilis. There's actually a subset, you can see 25 to 60% of people who will develop early neurosyphilis. This is different from tertiary neurosyphilis, but nonetheless, right, you could have tinnitus, you could have imbalance, you could have facial palsies, changes in vision, ocular syphilis. All of these are possible at the beginning. And so it's to dispel that myth that neurosyphilis is something that happens 20, 40 years down the road. So those are the two key pieces there. Second thing, just talking about this, is what we learn in the textbooks for syphilis is actually not that common clinically. So if we look at what I have highlighted there, the painless, solitary, indurated, clean base, right? So a single painless lesion at the site of inoculation, so wherever you got the infection from having sex, often for males, you'll see this around the coronal, or the coronal sulcus. Females, right, sometimes on the perineum. You may see this on the sort of frenulum as being a possible location. That definition, though, of what we think of a chancre, 98% specific. So that means if you see somebody who's sexually active and they have a painless, single, non-exudative base lesion that's indurated, it's probably syphilis. But sensitivity is only 31%, which really means 7 out of 10 times syphilis chancres look absolutely nothing like what we're telling you. They can be multiple, they can be painful, you just don't see them, right? There's all these different things. They can be exudative, maybe non-indurated, maybe it's just a little scab, maybe it's a macule, right? Because this will progress from a macule to a papule that will have a central ulceration. But maybe the person is just really aware. Maybe they know syphilis is increasing and they say, I've got this red bump. I've been sexually active. Can you take a look at it? And you're like, that's just like a papule. Like it's a discolored papule that's non-tender whatsoever. And so it's just to say, well, if you see the textbook picture, you're looking at syphilis, but don't expect, because 7 out of 10 times it's going to look like something totally different. The rash is actually probably more difficult. It's going to look like anything but vesicular. So if you're looking at blisters, it's not syphilis, but any other rash potentially could be. Now, most rashes are not syphilis, but without diagnostic testing, right, without our serologic testing, it's actually difficult to rule this out at the point of care. So always a good idea just to say, right, if you have risk factors in the context, meaning person sexually active, if you have risk factors in the context of compatible symptoms, it's always a safe, good practice to just do the blood test and rule it out. Next, and this is on the side, this is for guys who have sex with guys. This also applies to females. And this really relates to if you are the person in the sexual partnership who is being penetrated, so something's going inside of you, more often than not, we don't actually see symptoms until secondary. And this is because if you do have that classic lesion that's painless, and this is on your rectal mucosa, or it's inside the vagina, or it's on the cervix, how are you going to know that you have a single painless lesion inside your bum? You're probably not. We're not going to be doing anoscopes all the time looking for, right, lesions that may or may not be there, that we may or may not even identify. All of this to say is people will show up with rashes, and then we went through the primary phase unable to ever locate or even know there was a primary lesion that had preceded it. So don't rely on, right, that the person doesn't remember having a lesion to really say it's not primary. How do we test? This is actually probably the simplest thing, and there are 2 ways to do this in Ontario. Hopefully we have some advancements soon, but there are 2 ways. The typical way, serology on the right, is we do a blood test, send it off to the Public Health Ontario lab. It's really the only licensed lab in Ontario to do the testing, and they will run an ELISA, an EIA test. Key pieces to that. One is if you do think it's a primary infection, or the person says, hey, my sexual contact from 2 to 3 weeks ago was just diagnosed with syphilis, and you run the test and it comes back negative, it doesn't actually rule out syphilis, right? Because we have to move through the primary phase, so sort of 4 to 6 weeks from potential exposure, and that's when we will increase the sensitivity of this test. So primary infections, brand new infections, 75% sensitive. Other way to, I always like to invert these numbers, means that 1 in 4 times we're going to actually have a false negative. 1 in 4 times we're going to miss an infection that's actually there. And I think I encounter this pretty frequently in the sexual health clinic, where somebody comes in and says, one of my partners was diagnosed with syphilis. Okay, let's do the testing. Do you want treatment? And they say, well, this happened before and I tested negative, so I was needlessly treated. And I'm like, well, actually, we don't know that you were needlessly treated, right? To put that in quotes. What we know is that your lab, you were exposed, right? And your labs came back negative. Maybe we actually just, you became aware so quickly, we treated you so quickly that you'd actually never seroconverted and developed antibodies. They may have actually been exposed. They may have had syphilis in their body, but we treated it and eradicated it before the person could have seroconverted. So it's always a good practice to do this. Moving into secondary syphilis, the test should, in fact, in the RPR, should be approaching 100% sensitivity. I'm saying 98 to 100%, and that's only because you could really have a prozone effect. And that is, we always think of what's the minimum amount, right, of something that has to be present? What's the minimum viral load? What's the minimum, right, bacterial count? Whatever it is, what's the smallest amount that needs to be present for our test to consistently detect? That's the bottom threshold. And that's usually what we think about. People forget, though, that there's usually an upper limit to a test as well. And so sometimes the RPR actually just, there's so much
Sorry, it's not very loud either.
of the cardiolipin. There's just so much of it present that it actually flips the test back to negative. Barring
These are
that,
the worst speakers.
I think.
Remember to
Sorry,
mute
can
your
everyone
mic,
mute their-
folks.
They've been muted. Patrick, continue.
Okay, thanks. So 98 to 100%. So it's really barring that sort of little small spot, but it really is exceptionally sensitive. There's also, though, a DFA, a direct fluorescence assay that can be done. And this is actually where you take specimen collection specifically from a lesion. This will work in primary or secondary. And I'm going to go to the next slide. Oops, I'm going to go to the next slide here to actually show you how to do this. So on the public health requisition, right, that's on the right, we'll start with that. You take that, you put on the submitter's name, so the physician or nurse practitioner. Under site, right, you're going to actually mention where you're taking this from. So this could be, right, penis or corona. This could be vulva, right, as we're seeing in the images over on the left. And then what you put in the requested test is syphilis DFA, right? And that's specifically what you're asking. To do this, you need to have a smear, is what we have there. And then you draw a 1 centimeter circle with a black permanent marker. I think we traced a dime there, so it's actually quite a precise circle. I never actually have it quite that precise when I'm in clinic. It's just to tell the lab technician, right, this is the spot that I touched to the actual lesion. Look here under your microscope as you're doing your DFA analysis. The utility to the DFA is it can actually detect, and you can see for the sensitivity, 73 to 100% for primary and secondary. Where I find this useful is somebody with a brand new primary lesion. You can actually do this test, and they're actually going to analyze specifically for, right, T. pallidum, and you're going to get a result back that says T. pallidum detected or no T. pallidum detected, right? So you actually get a direct test for syphilis, and we found that not a huge number of cases, but maybe 10% of our diagnoses in Ottawa actually come where the person is DFA positive. They're positive on the swab, but they're actually negative on the blood test. So it's quite useful to add in. It's also useful in secondary syphilis. Like if we're taking a look at the vulva there, some of the lesions, particularly closer, the perianal lesion, right, you have discoloration, you have, right, that hypopigmentation, the blanching. Right, could this be an AIN, right? Could we actually be looking at cancer there? If you do a lesion of that and it comes back and it's positive, right, saying, no, this is in fact syphilis, these are going to really just disappear once you give your penicillin treatment. And it's reassuring because not only are they going to go away, but you know, in fact, what you're looking at is syphilis, and that you're not having to do some other investigation, because having syphilis doesn't preclude you from having other lesions or other types of symptoms or conditions. So it's really saying, no, in fact, the entire cluster of symptoms you're looking at do relate back to syphilis. So how to stage? This is always a question we have. And the main thing here is you cannot stage based on RPR. RPR is one of the factors. And so looking at these labs, before we get into how to actually do the staging, looking at these labs, starting in the top right, we have actually in all of them, right, the antibody screen. So the CMIA that we're using is reactive. First one, the RPR is non-reactive, the TPPA is reactive. The second, the RPR is a 1 in 8, and the third down at the bottom, the RPR is a 1 in 4 and a previous reactive. So the lab process in Public Health Ontario is they'll run a screen. If the screen, right, the antibody screen is negative, that's the end of the road. If the antibody screen is reactive, then they actually go directly to the RPR. If the RPR is reactive, we have in the middle one, you have a positive screen, you have a positive RPR, that is the end of the testing. They'll report that back to you. If the person has previously had syphilis, right, and done a positive result and it was linked to their name, Public Health Ontario has that, right, if they're going to put the TPPA in as a previous reactive. If, however, so I'm going back up to the top one over on the left, if the screen is reactive and the RPR is non-reactive, then they'll run the TPPA. So basically a second type of TP testing, treponemal specific testing, done with a slightly different methodology to say, first one came back positive. Let's rule out, right, that it's reacting with something else. The TPPA is just looking at it, from a slightly different angle to say, when I look at it this way with the screen, it's positive. I come over here with a different methodology and I look at it, it's positive again. It's just confirming, right, that probability of a syphilis infection. But let's go through with these. So we have antibody screen, reactive, RPR non-reactive, TPPA reactive. The only thing I can infer from this for staging is that's not secondary syphilis. All right, going back to this slide where we should have an RPR that's 100% positive, right, when we have secondary syphilis, that's not there. So the only thing I can infer from this is that it's not secondary syphilis. This could be a brand new infection. This could be an old infection. This could be an old treated infection. This could be an old untreated infection. All of these are possible, right? It could be a primary, it could be early latent. All of these are right on the table. So staging from the actual lab is impossible. Moving into the second one, now we have an RPR, secondary is back on the table. This could be anything, right? This could be brand new, primary. This could be secondary. This could be early latent. This could be late latent. This could be treated late latent. All of these are possible. Moving into that bottom one, exact same thing, right? So I'm not really able to discern a lot of information other than saying, I have a lab result that is positive for syphilis, and now I need to go and do the rest. And the rest is history, right? Has the person had syphilis before? When? What were they treated with? Do they have risk factors? And what's their epi profile? And epi profile I really mean of, are they in the groups that are most affected by syphilis? At the beginning, I said things are shifting. They absolutely are. But if you look consistently, males account for most of the cases, and this is really everywhere in Ontario. And specifically within that, it's guys who have sex with guys. So a guy who has sex with guys who comes in, right, and he's got some lesions, and you get one of these, you are most definitely looking at syphilis, and we're able to proceed with that. Physical exam is the last component that's important. Looking, does the individual have lesions? Do they have rashes? And been any indications, right, over they're saying maybe they have ringing in their ears, a new tinnitus, or a change in vision, or anything that's coming up with that, a neuro exam would be indicated as well. So you put together the history and the lab and your physical exam, and then we can stage. And this really, going back here, is primary, secondary, must be symptomatic. Early latent and late latent. Latent by definition is asymptomatic. And then tertiary, being exceptionally rare, in fact, we don't see this very much, is symptomatic again. It is not unusual in Ottawa Public Health for us to have somebody in the community do some testing, comes back and they say, I have an asymptomatic primary infection. No, you have a new infection, right? But it would be early latent, because if they are asymptomatic, they can't be primary or secondary. Primary is going to be, and over here are lesions, right, at the site of inoculation. Secondary is effectively where the person is seroconverting and becoming bacteremic, right? So the infection is actually moving right throughout their blood. That's really what we're looking at. So primary, localized, right? It's just at that spot at the site of infection. It hasn't moved out yet. It's slowly starting to seed throughout the body, but it really is localized. When we get into secondary, the immune system is aware that it's there. People can have flu-like symptoms, right? They can have the rashes, they can have lymphadenopathy. This may be localized or generalized. They can have patchy alopecia, right? Effectively anything at that point, fevers, chills, flu-like symptoms, they all become possible. But asymptomatic, you can't be primary or secondary. You're a latent. And this, looking at some of this information as well, saying that it's sometimes hard to find these lesions, or the rash is so subtle that you may not even know it's there. I really say when we do have a lab that's testing positive, right, any of these that are here, you do need to do your physical exam. This isn't just asking a patient, do you have symptoms? No, I don't have symptoms. Because my experience of triaging in the sexual health clinic for years has always been, do you have symptoms? No. So that means you don't have any discharge, and there's no burning, and you don't have pain, and you don't have rashes, and you don't have lesions. I'm like, well, I have all of those. I just don't have any symptoms, right? So some of it is just the language that we versus patients know. It's our job to do that review of systems to say, do you have symptoms? No. I want to confirm then that you don't have any of the following. And some people be like, oh, no, I do have that. It's not their job, right? We are trained, we are paid to know what the appropriate symptoms are. So it's good to just list them all off and go through it. But then it's subtle, it's difficult. Sometimes you have to be exceptionally good, right, at yoga positions to even be able to see some of these lesions in your genitals. So it's doing that exam as well. Do I see any lesions in your mouth? Are there any genital lesions? Any site that the person is using for having sex, lay your eyes on it to say, are there any actual lesions there that I can see, any symptoms, any lymphadenopathy, anything that would be appropriate, and then you put it together. Once you've got that, the main thing you're focusing on is, has this person had syphilis for more or less than 12 months? Right, and back to here again. As you can see, this infectious and non-infectious, that really breaks, at least according to the Public Health Agency and the CDC guidelines, this breaks at 12 months. If you move into the European CDC guidelines or into the WHO, they actually break it at 24 months. And really the takeaway from this is stick to our guidelines in Canada, which say 12 months. In fact, all North American guidelines say 12 months. But no, it's not that when you're on day 366 that suddenly you're not infectious anymore, right? The vast majority of people will move through the early latent into late latent by 12 months, probably around 95% of people, but there's going to be, right, a residual component who will actually take a little bit longer and they'll be infectious for a bit more time, but we use 12 months. How do we know then if somebody has an infection under 12 months? Clinically, this is my approach. I am going to treat somebody as if they have late latent syphilis until I can talk myself off that cliff and decide that I need to give them less treatment, right? So I'm going to always start with the higher. And so with that, let's go to the actual treatments. I'll just list them off and then I'll get into how I make this decision. So primary, secondary, early latent, and this is going to be people who have had the infection for less than 12 months, benzathine penicillin G, long-acting, right, bicillin, 2.4 million units as a single dose. I have also encountered this infrequently, but more often than I would like to see is sometimes people say, we follow up and say, okay, you had a patient who was diagnosed with syphilis, and you gave them the injection, and say, yes, we gave them the injection. And we're like, it was the 2 needles, and they're like, nope, it was just 1. When you order this medication, it comes in syringes of 1.2 million units. So it's 1 dose, but it's 2 injections. So just that is a key takeaway. Make sure people are giving the 2 injections. 2.4 million units is 2 injections of 1.2 million. That's how it's supplied. 1 dose only if you've had the infection for less than 12 months. If it's more than 12 months, you're going to do the exact same thing, benzathine penicillin G, bicillin long-acting, 2.4 million units, single dose, but you're going to repeat it a week later, then you're going to repeat it a week after that. So it's 3 doses, right, if the infection is longer than 12 months, like when they acquired it. If there's some reason you can't use penicillin, person has an anaphylactic reaction, it occurred less than 10 years ago, we know it was a true reaction to penicillin, then you can switch over to doxycycline, and this is for, right, that infectious, so less than 12 months, doxycycline 100 milligrams by mouth, twice a day for 14 days. And if this is potentially more than 12 months, then you just, the exact same thing, doxycycline 100 milligrams, POBID for 28 days. For pregnancy, there is no alternative other than the bicillin. And so if the person is in fact, right, allergic to penicillin, send them off to ID, right? And they will do their inpatient treatment. They'll desensitize, right? And all of the follow-up will be done. For pregnancy, it really is the only treatment that's available. Now, why is bicillin, the benzathine penicillin G, preferred? One, we have the most evidence about it. We know there's really no drug resistance, antimicrobial resistance to it whatsoever. And lastly, one of the things that I never really talk about clinically, but I have in my head, is that when you do use bicillin long-acting, you actually render the person non-infectious within 24 hours. So it's actually pretty fast. And this is excellent because I will still always say, don't have sex for 7 days, but we all know, and we have all retreated many people who have not been able to, right, not have sex for 7 days. So in this case, at least we know, right, this is going to work. This is also excellent for people who don't have decision-making power about when they have sex. Maybe it's an abusive relationship, or an individual who this is their livelihood. They're engaging in sex work to pay the rent, to buy food, to feed others, right, to clothe and house others, and then just say, like, I can't not work for 7 days. I'll still say, right, the recommendation is 7 days, but you can know and be like, really just don't have sex for the next 24, 48 hours. That's the absolute imperative part. Try to go to the 7 days, but like working with individuals to say, we need to treat you for syphilis, but we need to keep you safe as well. Doxycycline, we're uncertain of how long it takes. It probably takes a little bit longer, but there's really not much or much less evidence on how to do this. So how do you choose this? I've talked about more or less than 12 months. And then I've talked about what we actually use. So I'll really just be talking about the treatment options now. Somebody comes into me, I assume they're not allergic to penicillin, and there's no reason why they can't be taking penicillin. I will approach the patient and say, you're getting 3 doses of penicillin. You're getting treated for latent syphilis, unless I can convince myself that you have infectious syphilis. You've had it for less than 12 months, and that's pretty straightforward. How do I do this? You have unequivocal symptoms, primary or secondary syphilis, right? So the individual has a chancre, they have the rashes and the sort of distributed lymphadenopathy, things like this. That's option 1. They have unequivocal symptoms of primary or secondary syphilis. 2, they had sex with somebody who was just diagnosed with syphilis. So they're a true bona fide contact of somebody, not just I had sex with somebody and my other friend told me they have syphilis. And like, no, this is a person who they're a bona fide known contact of syphilis. We'll say, that is an early latent case. The third is we go back to the labs and we use them to help us infer. So this is somebody who's asymptomatic, because we don't have primary, secondary symptoms. If they did, our life is actually pretty straightforward. We can diagnose them based on the physical exam. But they are not a contact. They are asymptomatic and they have nothing, no signs on examination whatsoever. So now we're going to use the RPRs to say, is this a new case? A 4-fold or a 2-tube jump in the RPR. Now let's say, what does that actually mean? 4-fold is if you take the number and you multiply it by 4. So like, for example, our 1 in 4 down at the bottom, multiplying that by 4 would be a 1 in 16. So if somebody has a baseline of 1 in 4 and suddenly we get a 1 in 16, can you divide the new number by 4 and reach the old number or less, So we have a 4-fold or plus increase. We have a new infection. Sometimes we have to do this in tubes. And that's really the exact same thing, but you just non-reactive. You can't multiply 0 by 4 and get anything meaningful. So non-reactive is going to be you go to a 1 in 1, and then you go to a 1 in 2. So those are the tubes. The simplest way, I think, to understand this is 2 jumps. If I'm non-reactive, and then I jump to a 1 in 1, and then I jump to a 1 in 2, 1 jump, 2 jumps, that's a new case. If I have a 1 in 4, I go to a 1 in 8, I go to a 1 in 16, 2 jumps. So it's really, if the lab has jumped 2 times in an individual who is asymptomatic and they are not a contact, and this jump has occurred within 12 months, that's the third reason that I would be able to say, yes, this is a brand new infection. Putting that aside, they're getting their 3 doses. And it's really to say, which way do I want to be wrong? Would I rather overtreat with a little bit of extra penicillin, And basically it's just overkill. And the risk in that case is that they have to take up a couple more appointments and, they're getting the injections and they are unpleasant. But that's the risk. The risk of undertreating is if this is somebody who could get pregnant and does get pregnant, you have the risk of vertical transmission and congenital syphilis, and you have the risk that you've undertreated them and they could progress along to tertiary syphilis. So I always start with, I'm not giving you 1 unless I talk myself up to 3. It's always, I'm giving an individual the 3 doses, of arbenzapine penicillin G, unless I can, again, talk myself off that cliff and say, no, I am absolutely confident that I am not leaving this individual at any risk of harm in the future if I step down to 1. And that is, again, they're primary, secondary symptoms are present. We have that 2 jump within the last 12 months, or they're a contact. That's really what that comes down to. How do you get this medication? You order from your public health unit. You go onto the website and you can see there is an ordering form. There's a little note there as well to say this isn't just an order to stock and have it around in case, but if you do have somebody who is diagnosed, you can order and it will be sent over to you, And it's all basically on the website, so you'll be able to go on and get that and get these medications sent to you for free. Key point there, they do not have this in pharmacies. You can't write a prescription and give it to a patient and say, go and pick this up at a pharmacy. You do need to order it from your local public health unit, right? And this is your actual process locally for you guys. And then, right, that will be sent to you and you bring the patient back for treatment. Follow-up. So now we have assessed them, we have staged them, we have diagnosed them, and we have to do some follow-up. The follow-up guidelines really, if we look, and this is an article that I wrote with one of my colleagues up in Ottawa, was we just laid out what does the Public Health Agency of Canada guidelines say, what does the US CDC say, what do the European CDC guidelines, the UK sets the BASH guidelines, and WHO say for when you should follow up. And I find when you look at international guidelines, because they really all use the exact same body of evidence, when you start seeing commonalities, it tells you, right, key points. So Canada says do repeat testing at 3, 6, and 12 months. The CDC in the US says 6 and 12. Europe says 1, 3, 6, 12. UK says 3, 6, 12. And the WHO says the next time you can get them into care, no matter where you are, right, do a test at that point. But looking across the commonalities here, 3, 6, 12 is pretty straightforward. So you'll want to see this person 3 months, 6 months, and 12 months, asking them, right, any symptoms, any concerns, and repeating the blood work. Then you should be watching the inverse of what I said on the RPR going up. You want to be able to divide that by 4. So you want that 2 jump in the RPR downward. Right, so you go from a 16 to an 8 to a 4, hopefully to a 2 to a 1 to non-reactive, but some people will never become non-reactive, but you really want to be able to go down 2 jumps to say the individual is treated. When should you see this? Looking across the guidelines, Public Health Agency of Canada has a lot of extreme detail. The US CDC says 4-fold by 6 to 12 months. The Europe CDC says 4-fold by 6 months. The UK says 4-fold by 12 months, and the WHO says just 4-fold over the next couple tests that you do. Following the Public Health Agency, and again, an interesting point with this, if you look at all these guidelines, they all reference the exact same studies, and everyone, United States, Europe, UK, World Health Organization, they all really settled on a 4-fold drop by 6 to 12 months would be considered successful treatment. And the Public Health Agency just went rogue and came up with these really high thresholds for treatment. What I use clinically, ID in Ottawa as well, what they use is really the 4-fold by 6 to 12 months. Because if you get into, you should have, right, an 8-fold by 12 months, 16-fold by 24 months for primary. A lot of people will fail this, and you're going to end up sort of over-referring needlessly, potentially over-treating needlessly for, right, a non-failed treatment that everyone else, anywhere else in the world would have said, no, this is actually adequate treatment. We have no problems with this whatsoever. 2 other key things is an inconclusive result. People get these and it confuses them. And I don't think the way Public Health Ontario writes on the lab for this is super useful, because they often put right, this is a false positive repeat at 4 weeks or so. And that's really what they write on the lab. That's useful, but you need to put a little bit more context into this. If you have somebody who this is the first time you're running the test, and it comes back inconclusive, and they're asymptomatic, and there's no particular risk factor for syphilis, potentially, right? That's not a bad approach to do. But if you have a patient who you actually see every 6 months for testing, and they've always been negative, and suddenly they have an inconclusive result, what has changed for them, right, on this immunologic screening that we're getting, what has changed for them? In many cases, this actually could be a brand new seroconversion. They're a very, very low detect, right? And so it's basically, if you repeat it in 4 weeks, you're going to go up to a true test result, right, where you have like a positive across the board. But I think we just want to think about it and say, if this is a change with somebody who has risk factors, are you just catching an early seroconversion? And we looked at this in Ottawa, and we actually found that of our inconclusives, as we played this out over 6 months, we ended up having to treat 50% of them. About a quarter were in fact new infectious, and the other quarter were old non-infectious cases. So these are individuals who had syphilis for a very long time, and their antibody levels were in fact just waning. But it really meant that most of the time, despite the fact that the lab has, right, likely this is a false result, but it may be new, maybe old, repeat in 4 weeks. It's really to put this together on, again, when I said don't stage based on the lab, stage based on the patient, right? What's the history? What are the risk factors? Do they have signs and symptoms? You have somebody who has a chancre and a new inconclusive result, I guarantee that is primary syphilis, right? And we really want to be treating that. So don't just dismiss inconclusives. Treat the patient, not the lab. Take a look at what we have to do for that. The other one of importance is pregnancy, and that is, as we're seeing congenital syphilis go up, this is much more of a problem for us now. We've said that if you're over 12 months for syphilis, it's considered non-infectious, but this is for sexual transmission and not vertical transmission, and that's a key point, right? Even we're getting to late latent, there's an under 10% risk, but there is still upwards of maybe a 1 in 10 risk of vertical transmission, right, from a mother to the fetus, even in late latent syphilis. So while that individual may not be infectious through sexual contact to somebody else, the vertical transmission risk does exist. And this is again where, if I'm making a decision for somebody on to treat them, I'll start with the 3, because I can actually think of a few cases locally in Ottawa where somebody was at risk, did have syphilis, they were treated with a single dose, they came back on prenatal screening, and we look at it and we're like, this was probably always a late latent infection. You've been inadequately treated, and now we do have a risk of a very real risk of congenital syphilis that we have to manage. And so it's like, okay, how do we make sure we don't do this? Remember, right, that we really want to err on the side of, okay, we're going to give you full treatment unless I have concrete evidence that I don't need to. Testing in pregnancy. This is actually from the antenatal guidelines. You test, right, basically your baseline. You're going to do your Rh factor. You're going to do your CBC. You're going to check for, right, Hep B immune status and rubella, right, all of this. Syphilis is supposed to be a test with HIV at that point as well. And the antenatal record also says repeat in trimester if ongoing risk. And you can see repeat screening at 28 weeks. So this is from the Public Health Agency of Canada STI guidelines, highlighted in gray and bottom. Repeat screening at 28 to 32 weeks. And again, at delivery is recommended for pregnant people at ongoing risk of infection or reinfection, and in areas experiencing outbreaks of syphilis. Now, we've never actually had an outbreak declared, but I'm not entirely certain if 2,540% increase in congenital syphilis doesn't constitute an outbreak, right? In my mind, it does. And so I just think, right, doing, right, more frequent, regular syphilis testing in the context of pregnancy it's a good idea. It's a very good practice. The harms can be catastrophic. The testing itself and the treatment is in fact quite simple. So it's a very simple test. It's a very simple intervention, but when missed, right, or delayed, this is where we more end up with issues. So for pregnancy, what do? You have a positive result, a new positive result, or an old positive result, but let's say it's a new one just to make our life simple. In somebody who is pregnant, you will want to refer to high-risk obstetrics, pediatric infectious disease, adult infectious disease. So you're doing 3, right? You want to basically manage the pregnancy, you want to manage the baby when born, and you want to manage the person who is actually pregnant. So 3 things need to occur, but waiting for these referrals shouldn't delay treatment, right? You could actually treat as outpatient, particularly if this is a first trimester screening that you're doing. You will then provide treatment or retreatment unless all of the following are fulfilled. You have adequate treatment, right, of a previous infection, and it's documented. This isn't just the patient saying, oh yeah, I had syphilis treatment before. You really want to get evidence of this to say, I want to make sure, right, that we're not going to be missing something here. Then you're going to look at that treatment and say, is it correct for the actual stage? And for pregnancy, right, these doses, well, I said, right, it's prescribed as every 3 days if we're going for like longer, like late latent treatments, right, the 3 weeks of treatment. Most of the time we can go up to 14 days. So somebody shows up on day 12, right, you can just give them the next dose and then continue a week later. For pregnancy, though, we really want to be less than 9 days. So if somebody misses their 7th day and they need to be coming back, I would make efforts to reach out to them to say, hey, you missed your treatment today. Like, we don't have many more days. Can you come in tomorrow? How do I get you in tomorrow? Can we get someone to you? Like, just to make sure that we didn't fall off. Then adequate decrease in RPR appropriate to the stage, documented, and no risk of reinfection. So let's take a case that I had to manage a few years ago. So we have a lab received for a 36-year-old female. The CMIA is positive, the RPR is a 1 in 1, and the TPPA is a previous positive. Testing done for prenatal screening, asymptomatic, nothing identified as particular reason for testing for syphilis, just doing prenatal antenatal screening. Sexual history, positive syphilis lab from about 2 years ago. At that time, the RPR was 1 in 8. She was asymptomatic. She was staged as primary, and this was because the patient reported negative syphilis labs 8 months before. However, no evidence was actually in the chart to confirm this, but the patient said, no, 8 months ago I did testing and I was negative for syphilis. She was, based on primary syphilis stage, appropriately treated with benzathine penicillin G, 1 dose. So let's go back. All of the following are fulfilled. Adequate treatment documented. Okay, so we do have, a stage, and we do have appropriate treatment for the stage. Great. Going the wrong way. Do we have the correct stage? That's a bit more questionable. Do we have an adequate decrease in the RPR? Well, we've gone from a 1 in 8 to a 1 in 1. So we have 2 plus jumps, 8 to 4, 4 to 2, 2 to 1. So we've actually jumped 3 times. That's great. We have that one. And no risk of reinfection. Well, there is ongoing sexual contact. Really only way to end up pregnant. Well, one of a couple ways to end up pregnant, but the main one that people end up as pregnant. And so we're saying that's the case. But we actually take a look in OLIS. We're connecting Ontario specifically to say, okay, well, we want to see that negative syphilis lab from 8 months before. It was actually never done. There was a CBC done. They were actually really checking at that point to see if the person had any anemia or any other thing, but there was actually no syphilis testing previously done. So we have a woman who has a relatively low RPR of 1 in 8 without symptoms, who's treated with a single dose. Can I be confident here, that this person, in fact, didn't have latent syphilis at the time? I can't, And so what I'm looking at here is 2 years ago, this person should have actually been staged as syphilis of unknown duration or latent syphilis, and they should have received 3 doses of benzathine penicillin G. Now we have a potentially undertreated infection in somebody who's pregnant, and if they were undertreated, this may not have treated their latent syphilis. We may be at risk for vertical transmission, And so this is where it gets into us being really saying, do we have the documented evidence? Am I confident that I'm not undertreating you? If we want to get ahead, going all the way back to the beginning, if we want to get ahead of these numbers, being a bit more laissez-faire and saying, I don't want to subject you to this isn't going to help us. We need to come together and say, how can we actually make sure we're treating every single patient who tests positive appropriately, and that we're not leaving anybody at risk. And we're not this person thought they had done everything that was correct because their health professionals had guided them as such, but there was still a risk. And so we did retreat this person to be absolutely certain. So on to, I keep going back and forth, the summary. Key takeaways here are the epi has changed. We're seeing syphilis moving from what it was exclusive, actually it was gone, almost 20 years ago, 25 years ago, to guys who have sex with guys. And this is funny because in Ottawa in 2008, we set up a gay men's STI clinic called Gay Zone. And that was, I laugh about this now, it was because we had 5 cases of infectious syphilis in 2007, and everyone freaked out. Last year, we had 400 in Ottawa. So it's just quite a different context that we're looking at. But the epidemiologic profile is changing quite dramatically. I will weekly treat guys who have sex exclusively with women, women who have sex with men. I'm treating every week somebody who 10 years ago, I would have said, no, it's always guys who have sex with guys. But every week now, I'll be treating somebody who's heterosexual, and every week I'll be treating a woman. Test and retest. As the main thing with syphilis, people are sexually active. Test and retest, whether part of antenatal follow-up or anything else. And then management, treat cases, including inconclusive, if you are thinking about it, and contacts. And the key thing with contacts that I didn't mention earlier is the transmission risk of syphilis per sexual contact per partnership is probably 30 to 60%. Let's benchmark that against HIV, which we say, is less than 1%, 0.1, 0.5, maybe up to 3% max. We're going from a risk for HIV, maybe 1%, to this upwards of 60%. So it's highly infectious. So context, I always say, right, let's just do the treatment. And then benzathine penicillin G is the first line ideal treatment. Please use that unless there's a reason not to. And that's, yeah, hopefully how we can start managing syphilis better and changing that curve so it starts to look more like a bell curve where it's coming down. So I've left a bit of time for questions if people have them.
There is a couple in the chat.
Oh, there we go. I couldn't
Thank
see
you
that
for
because I
that.
only have one screen, but let me look here.
Draw me, I can just read it out as well.
Where are we? I should be able to find them. I recommend approach if positive result and neuroocular complaint in office. This is, you can't rule out ocular, so this would be a consult ID or ophtho. That's really the main thing there. And the issue with ocular syphilis is somebody has a change in vision. Let's say that's their complaint. It's very difficult to tell if this is neurosyphilis, cranial nerve 2, or it's actually infection that's gone into the globe of the eye. Clinically, they will present the same to us. Ophthalmologists, with their wizardry of the ability to look at the back of the eye, are going to be able to actually say whether or not, right, it's an ocular infection or if it's neurosyphilis. And then that will be the decision on, right, is it ophtho or is it ID? What we do in Ottawa is usually if we are potentially concerned that it could be ocular syphilis, we'll send to ophtho, and then our ophtho will reroute to ID if it's not them. So that's the pathway that we have locally, because it's probably, actually, this is what ID will say. They're going to look at the back of the eye with a fundoscope the way I am, and you're going to say, that's red. Yep, I can see some vessels. I don't know what's going on there. And so ophtho is probably your best bet in that regard. Next, what are other reasons for an inconclusive result other than an early indication of infection? If we retest an inconclusive result after 4 weeks and the result remains inconclusive, can we be confident is a false positive? So first part, what are other reasons for an inconclusive? There are other treponemal infections, yaws, pinta, that will do this. Will give you basically an inconclusive result. They are treponemal pallidum infections, but not pallidum, which is specifically what we're thinking of for sexually transmitted syphilis. Other organisms, the good thing with that is that if somebody has yaws, you treat them with the exact same treatment, it's still benzathine penicillin G. So the harm to that is actually nothing per se. It's just like, do you want to miss it? The other thing to consider, though, is it could be an old infection where the antibody level has waned. Think of hepatitis B. You run your surface antibody and you know the person was immunized, and suddenly you get a result back that says it is 2.58, right? Million international units per mil. And the antibody level has just waned over time. So that's another thing that can happen is in an untreated or an old treated infection, the antibody level can come down to such a point that it's dropping to basically around the level of detection. And just like with your hepatitis B surface antibody, any titer will wane, right? Unless sort of you're re-exposed and continually boosted, the antibody level is going to wane. So how do I discern between an old treated and an old untreated? Were you ever treated for syphilis? I simply ask the patient. That's pretty straightforward. But other things can do it. Immune conditions can also cause it, so it's not always the case. That kind of, I partially answered the second one to say that if you repeat it 4 weeks, does it absolutely rule out syphilis? It doesn't, right? Because if they have historical and they say this is somebody who is, I don't know, 50 years old and like I've never done syphilis testing, this could have been an infection they got when they were 18 years old, and it's just been there, right, for such a long period of time, and the antibody level has come down quite a bit. So you can't be 100% confident if it doesn't change that you can rule out. Gives you good certainty, but you can't be absolutely confident. Next one. Do we know how early on in pregnancy a client must be treated to avoid a congenital syphilis diagnosis for a neonate? So syphilis, interestingly, is actually not damaging to cells. It's not inherently destructive. What syphilis does is it causes immune system reactions, and then your own body destroys itself. And that's really what it does. It causes an inflammatory cascade, and it's that inflammatory cascade in syphilis that actually causes all of the harm to you. That's one of the reasons the chancre is painless, is because it's really just sort of deterioration caused by immune system activation, as opposed to a cytotoxic bacterium going in and causing an issue. So when do neonates typically start developing their immune system? Probably somewhere around 18 to 20 weeks. So treating before that, there is really no sufficient immune system in the fetus to cause harm. So first trimester screening becomes exceptionally important because it can't have caused harm, because it's not cytotoxic, and there's no immune system to actually activate and start causing harm in the fetus. So this is where that first trimester screening, but basically before the immune system develops, is your safest bet. But yeah, I encourage people, screen at the outset, right? Get this going, because if you identify it, you can treat it right away. There may be transmission, but there shouldn't be harm. Matt also had a pregnant patient with a late latent treated, but non-compliant with serial testing for her and baby. Took 18 months for one late testing conclusive and did not repeat or attend ID referral. Baby seems well. Mom keeps saying she will rebook, doesn't go. How hard to chase? Child protective services needed. I think this would, less than CS, this would be just like your local public health unit, right? Involving them to say what follow-up, right, would you recommend? This falls within their purview, infectious diseases, right? Do they want to do the follow-up on this, right? And they'll be able to help you and assist you with that. How quickly do they need to be, and this is for pregnancy, I'm imagining, neuro, as fast as you possibly can. And ID opto, I mean, they're going to triage and see usually pretty quickly. One thing I have in there, the caveat, and this really comes from the CDC guidelines, although they're gone for a little bit. I don't know if anyone noticed that under the executive orders in the United States, in addition to tariff nonsense, they actually took down their entire STI guidelines for almost 2 weeks as they scrubbed them into the new language that they use. I believe they just came back a couple of days ago, but their language was very clear to say, if this is a first trimester infection, do the referrals, but you can treat right there, right? If you have the medication, you can treat at the point of care. So I would say, there's really not much harm in first trimester treating. This is 30 weeks. I'm not going to be super comfortable doing outpatient treatment. I probably want more involvement, right, in an inpatient setting. The Yarish-Herxheimer reaction, that's sort of that reaction that people can get after syphilis, can cause some premature contractions. And so that's not one I really want to mess around with if later, but if we're in an earlier pregnancy, it doesn't happen super frequently, and so it's just much better. Baby taken for one test that was inconclusive. Okay, I think that's follow-up. Doxy PrEP, when do you recommend? So the CDC guidelines, I actually don't even know if these ones are back. I think are really the only ones. The Public Health Agency of Canada does have a draft version under review with certain people right now. So BAC will have a guideline soon, but it's not publicly available. But the CDC guideline is pretty clear that this is for guys who have sex with guys and transgender women who have risks of STIs, having sex, and have had one or more bacterial STI, gonorrhea, chlamydia, syphilis diagnoses in the last 12 months. I think this is a good guideline. And the reason I think this is such a good guideline is we took a look in Ottawa. So we took the OHISI data, so the Ontario HIV Epi Surveillance Initiative, which uses a Sex Now survey where they go around every couple of years with FAC and they do sort of census-like testing for different infections. They estimated that it's somewhere around, I think it was 25,000 sexually active gay men in Ottawa, of which, when we pull IFIS, there are about 800 unique guys who have sex with guys who are diagnosed with a bacterial STI each year in Ottawa. So I think that threshold of just because you're a guy who has sex with guys, should you be put on Doxy? It's PEP as opposed to PrEP, so it's post-exposure, right? The 200 milligrams within, ideally right away, up to 72 hours after sex. PrEP is under more study. PEP is the one that we have the guideline for, just to clarify my own point. But to take 25,000 people and say all are eligible for taking antibiotics all the time, when only 800 will have an infection, I think that one diagnostic threshold is a good point. So then what we did with the IFIS data, so that's the reportable public health data, as we said, well, let's go forward. How many of those 800 guys have another infection within 12 months? And it was around a third, right? So it drops down to, it was like 275. And then of that 275, how many have a subsequent infection? Again, it was around a third. So there was no sweet spot where you get this super great return on investment that it's like, well, if they've had two, it's a 50%. It was always stepping down by a third. And we said instead of 25,000 to 800, 800 to potentially prevent around 275 infections. We're like, that's actually pretty reasonable. And so I think we have local epi data supporting right what the US CDC has as well. The next one is a reminder, any experience in treating possible early neurosyphilis, the doxycycline. Not entirely certain it's going to penetrate brain quite as well. Penicillin would be the preferred. If it's the only thing you can get, it's the only thing you can get, but I don't think there'd be any confidence that that's actually going to work. Even because the IM penicillin, we don't think is going to penetrate the blood-brain barrier very well, and that's why it really goes to 24 million units of penicillin IV, right? When you're moving into neuro or ocular syphilis, otic as well. So I'd say no, I wouldn't really feel confident in that. But if it's the only thing you can do, absolutely, it's gonna it's not gonna work. I just can't guarantee that it is gonna work. And if that's the only treatment we can do, it's probably better than absolutely nothing. I think that's the end of the questions.
Perfect. Thanks so much, Patrick. It's
1
great
minute
as
over.
always.
My apologies.
It's all good. So I have a slide that may not work to share because I am not super techie. But can you guys see the slide?
Yep.
Okay, woohoo! Yay. So this is just our contact number for the sexual health clinic. The phone number is typically live answered, but mind you, we're in and out of the day seeing patients, so it's not always live answered. I'm only here 3 days a week, so if you are trying to reach me, it's best to go through the main contact number and the nurses will pass on the message to me, and this is my email. If you're trying to speak to infectious disease, if you're worrying about neurosyphilis or some symptoms that you're a bit concerned about, you just go through the Brantford General switchboard and request to speak to ID on call, and they'll patch you through. Dr. Laura Erdman is also a PEDS ID doctor working out of MAC. That's more than happy to take referrals to help manage those congenital syphilis cases and make sure babies followed and treated adequately, assessed, and everything like that. So thank you very much. Again, thank you so much, Patrick. It was great. So I want to thank everyone for attending. You'll be sent a post-session survey. It would be appreciated if you could complete this to give us feedback to guide future sessions. If you haven't been able to put your email in the chat so we can send you the slides and this post-session survey, please do that now. But otherwise, thank you everyone for making time in your day, and I hope it was helpful. Thanks, Patrick.